Hello, good evening everyone. Today, this is the first time that we're going to educate for the new parameters that I added in our new wound assessment form. So I divided it into two parts. First, we're going to differentiate the new parameters, which is pressure, MARSI, and MASD. And then the second part will be the assessment itself. Now, in our hospital, we categorize two. We have hospital acquired and community acquired. Now, how are we going to differentiate these two is by the hours, which is 24 hours. Now, 24 hours after the patient's admission, we considered it hospital acquired. Now, community acquired 24 hours within patient's admission, we consider it community acquired. Now, a very common misconception in our hospital is that, for example, the patient is admitted January 1 at 6 p.m. And the patient came already with a community-acquired pressure ulcer. Let's just say this is a stage 2. But then, the reporting of OVR was done on January 2. So even though that this patient came with a community-acquired stage 2 pressure ulcer, we still considered it hospital-acquired, We consider this hospital-acquired because of the reporting. Now, from the moment that you recognize there is a wound is present for the patient, it's very important to report it through OVR. Now again, these are the three things that we're going to differentiate today: pressure injury, medical adhesive related skin injury, moisture associated skin damage. Now let's go first to pressure injury. Now again, what is pressure injury? Always remember that pressure injury happens over a bony prominence. Okay? Over a bony prominence. Other than that, if the wound existed in other parts of the body where there is no bones, that means that is not pressure injury. I hope this is clear for you. Now let's talk directly about the stages of pressure injury. First, we have what we call the stage 1 pressure ulcer. Again, this is non-blanchable. How are we going to test for non-blanchable? We are going to press the area. If you're going to press this area and this doesn't turn white, it does not turn white, again, that is non-blanchable test of redness. Now, again, if you see any redness, first you're going to notice any redness on the patient's skin. Next thing you're going to ask yourself, is this located in a bony prominence area? Yes. If this located in the bony prominence area, then do your test. Do the non-blanchable test. You're going to press the area. If it doesn't turn white, that means it's positive. It's already stage 1. Okay, clear. Now next, let's go directly to stage 2. Now stage 2 is a superficial loss. Only this part, there is already an open wound for stage 2. Now the maximum depth of stage 2 pressure ulcer is 0.2 centimeter. Beyond this one, we consider it stage 3. Okay? The wound bed can be pink and without slough, because again, this is a very superficial wound, which look like this. Okay. Now next, let's go to stage 3. What happens to stage 3 is that the wound already goes deeper. Okay? We goes deeper and now we are touching the subcutaneous fats. We are touching the subcutaneous fat. Okay? There will be slough. Yes. Slough may be seen. There will be necrotic. Okay? But the depth will only be up until in your subcutaneous fat. Okay? Just like this. Okay? Now next, let's go to your stage 4. Stage 4 is there is a full thickness tissue loss. So what happens here? We are already going deep. We go past beyond the subcutaneous fat and now we are touching the muscles and the bone. Okay. Slough can be there, yes. Slough is present. Necrotic can be also present. But again, now it reached to your bone. Okay, like this. As you can see, the bone is very prominent in this example. Now let's talk about unstageable. What is unstageable pressure injury? Unstageable pressure injury is basically you cannot see the wound bed. Okay? You cannot see the wound bed. You cannot see how deep it is. We don't want to assume the depth of the wound for as long as it is covered. Now, I just want to clarify. Unstageable can be necrotic. It will be covered by necrotic. Or sometimes it is covered by slough. Now, the idea here, unless you will see the wound bed, okay, if you cannot see the wound bed, it means that is unstageable. Now, for example, this one. You see? You think that the depth is somewhat, okay, maybe stage 3, correct? But we don't want to assume, not unless we see the wound bed itself. How are we going to see the wound bed, ma'am? We are going to remove this one. Okay, we are going to remove this necrotic part or slough part. Because treating a necrotic or slough part will not help your wound grow or will not help your tissues grow. That's why if we see that this is unstageable, this is necrotic, as much as possible, we want to do debridement. Okay, I will discuss the treatment later on, not on this part. Now next, we have the suspected deep tissue injury. So suspected deep tissue injury. Now I want you to take note of this. This is a purple or maroon localized area, again under bony prominence, intact skin. Intact skin. Now, again, on our stage 1, we have an intact skin, right? But that one is only redness. Now, redness, intact skin, that is stage 1. Purple or maroon, intact skin, that is deep tissue injury. Okay, now here also we're gonna talk about blister. Now, there are two types of blister. If the blister is clear, that is stage 2. Now, if the blister is blood-filled, that is deep tissue injury. But then again, don't forget that you're going to diagnose it as deep tissue injury if and only if you are located in a bony prominence area. So for example is this one, a very good example of your deep tissue injury, and I know this is a very common a case in our hospital. Okay, next we have medical device related pressure injury. Okay, there is a device present on our patients and then wound happens. Now for medical device related pressure injury, we're going to stage this one. For example, when you remove this nasal cannula for the patient, and mind you, this is a very thin area. Okay, compared to your other parts of your body, this is a very thin area. So even though how shallow the depth of the wound, for as long as the bone is exposed, that is already stage 4. Okay, clear. Now we also have another one, which is what we call the mucosal membrane pressure injury. Mucosal membrane, and there is also a history of medical device. Yes, medical device is positive, but what is lacking here? How are we going to differentiate this medical device related pressure injury? Is the underlying bones, the underlying structure. Okay, if there is bone. Now this area of our nose don't have any bones. So if that is the case, the question, can I stage it? Yes or no? The answer is no, of course. We cannot stage. We can only stage if there is an underlying bone. Now here, I'm going to show you a slide. How do we differentiate two almost similar category? Now first, we have the stage 1. Both are intact skin. Okay, both are intact skin. Here red, here purple. Okay, as easy as it is. Next, we have the stage 3 and stage 4. Now, stage 3 and stage 4 both have necrotic and slough. Some parts of it. But on stage 3, you're only up until your subcutaneous tissue. You're only up until your subcutaneous tissue. For your stage 4, your bones, your ligament or tendon, or your muscles are already exposed. Okay. Then, now, a difference between your medical device-related pressure injury and your mucosal membrane pressure injury. Again, similarities, both has an history of your medical device. Medical device, you can stage. Mucosal membrane, you cannot stage. Because again, there is no underlying bone. Example here, this is a pressure injury caused by a tracheostomy tie. Okay, here for example, here if there is a tear on the patient's genital area because of the Foley's catheter, of course there's no bone on the male genitalia, so that means this is considered as medical device related pressure injury. So now let's talk about moisture associated skin damage, or what we sometimes call the MASD. So what is this? There are 4 types. We're going to discuss all of this one by one. Then let's define first what is MASD. MASD results from the prolonged exposure of the skin to moisture. Now, what are the different types of moisture that the skin can be exposed? Here, you have your perspiration, urine, stool, wound, exudates, and ostomy drain. Okay, anything moisture that is exposed to the skin with a prolonged period of time, that is what we call MASD. Now, here, first type is what we call the IAD. Incontinence associated dermatitis. This is the very common, what do you call this? A very common MASD in our hospital, but we did not diagnose it yet. That's why I'm adding it here in our new assessment form. Why? Because incontinence comes only from urine and stool. No other than these two. Okay? Now, this IAD is commonly misdiagnosed with pressure injury. Why? Because urine and stool happens only in your perineal area. Correct? That's why it's misdiagnosed. Now, how are you going to know? Of course, it's scattered. It's diffuse. Later on, I have a table differentiating IAD and pressure injury. But again, incontinence-associated dermatitis only from exposure of urine and stool. Next, we have 4 types for this one. 1A, 1B, 2A, and 2B. Now, for 1A, there is a persistent redness without clinical signs of infection. There is a redness only. Is this an open wound? No. No open wound. Redness only you are going to see on the patient's buttocks. Now, we have what we call the 1B. There is a redness with clinical signs of infection. Now, question, how am I going to know that there is a sign of infection? You're going to check the surrounding area. If you can see any white or yellowish flaky appearance, that means there is a sign of infection. Okay? Next, let's talk about 2A. 2A, there is already a skin loss, but then without clinical signs of infection. The area is already open. The area is already open. Open wound is exposed. Now here, 2B, there is a skin loss, and then there is a positive sign of infection. There is yellow already. There is, okay? Here you will see there is a slough. Slough can be present. Pus can be present. There will be a white scaling, and slough also may be visible. Here, yellowish, brown, or grayish. So, okay? This is the 4 types of your IAD. Again, you have 1A, without skin loss, persistent redness without infection. 1B, without skin loss, persistent redness with infection. 2A, skin loss, persistent redness, plus open wound. 2B, skin loss with clinical signs of infection, plus open wound. That's our first type, IAD, incontinence-associated dermatitis. Now, let's go to intertriginous dermatitis, or what we call IAD. This is results from the moisture trap between the skin folds. Yes, again, this is common in our hospital. We are reporting it as a pressure injury, a wound, but then again, it is located on the patient's skin folds. This is an example of the skin folds located in the patient's breast. Other than what, we have what we call the abdominal folds, correct? We have the abdominal folds, we have the inguinal area. Sometimes if the patient is obese, the on the thigh of the patient, on the arms of the patient. It is very, very common. Now, the third one is what we call the peri-wound associated dermatitis. Now, what happens? Irritation surrounding the wound, because the drainage comes from where? The wound itself. Okay, the drainage comes from the wound itself. Now, next we have the peristomal. Peristomal irritation in the surrounding area happens because of the ostomy. This is an example of a peg tube. And then the surrounding areas are very red. Okay, that's your 4 types of your moisture-associated dermatitis. Skin damage, sorry. Now, we have 3 categories: mild, moderate, and severe. Now, for mild, redness of the skin only. It's dry and intact. No open wound, okay? But it is at risk for breakdown because the irritation is already there. Now, we have the moderate. Moderate and severe, you're going to check only for the 50%. If it's less than 50%, that means it's moderate, the redness. If it's more than 50%, that means it is severe. Okay? Now, here are the difference. How are we going to differentiate between IED and pressure injury? Now, again, why these two are most commonly misdiagnosed? Because this pressure injury and IED happens in the sacral area of the patient. Now, for the color, it's bright red. Okay? For the color, it's bright red. And then, the pressure injury is deep red. Okay? Now, the location, the site. Where is the site for this one? For your, both can be perineal. Here, again, bony prominence. Now, I'll show you in example here. I don't know if we have here. No, this one. Yeah, this one. Okay? In this example, you will see that the irritation happens on this area, on the buttocks of the patient, not on the coccyx, not on the coccyx where is our tailbone located. It's on the buttocks. Okay, if the irritation located on your buttocks, that means it is a IAD. Okay. Now, what's next? Then the lesions, 1 or more islands of erosion. What happens to your IAD is that it is diffuse. Here, it is diffuse, it's scattered. And there will be a lot of open wounds, small, big, like that. But for your pressure injury, it's only 1. Okay? It's only 1. And always, again, remember, it is on a bony prominence. Now, necrotic tissue, you will not find any necrotic tissue on your IAD, but you will find a slough here. Okay, you will find a slough, but not necrotic. Okay, but for your pressure injury, you will find both. Okay, necrotic and slough. Exudate, yes, both will have exudates. But in short, the most common thing, how are we going to differentiate, is first the location. If it's sacral, it's moist IAD. If it's in a bony prominence, it's pressure injury. It's basically just like that. Now, the last one is your medical adhesive related skin injury, or the MARSI. What we call it in short is the MARSI. Now, we have 3. We have first, let's talk about skin tear. A wound caused by shear and friction, resulting from a blunt force resulting from the separation of the layers of the skin. Now, there are 3 types of skin tear. Type 1 is when your flap, this one, this skin here, you can still cover the wound bed, completely covering the wound bed. You can reposition it. For type 2, this is your skin flap. When you try to cover, you cannot cover all the wound bed. Half only or less than. For as long as you cannot cover the whole wound bed, that is type 2. Now, type 3 is an total exposure of your wound bed. The skin flap is totally removed and there's no way you can reposition it again on the injured area. Clear? Skin tear, again, you have 3 types. Type 1, you can use the flap, the skin flap, to cover the entire wound bed. For type 2, there is a partial covering of your wound bed. For type 3, there is no covering at all. Now, the other type of your MARSI is the removal of one or more layers of stratum corneum. Skin stripping. Look at this area. There is a plaster here because this is a cannula. Okay, this is a cannula. And then when they remove the plaster, the area is already irritated. So this is what we call skin stripping. Stratum corneum is the first layer of your epidermis. Next, our favorite of all is the blister. Tension injury or blister. Okay, there is a separation of your epidermis to your dermis. There is a separation. Now, we talk about blister on pressure injury, okay? And we have two types. We have stage 2 if it's a clear field blister, and we have a deep tissue injury if it's a blood filled blister. Now again, go back to your basic. If the blister happens on a bony prominence area, a bone is present on that area, then that is a pressure injury. Now, very common tension blister happens where? Inner thigh. Sometimes it just happens on the hands of the patient, sometimes on the abdomen, sometimes on the chest, and this is very common in our hospital. Okay? Now, in short, in conclusion, how are we going to differentiate these three skin types? Is we have to check our history. We always have to check for the history. As a primary healthcare provider for the patient, as a nurse, you know what is really the cause. Is it because of pressure? Is it because of moisture? Or is it because of adhesive? Okay? Adhesive or your skin tear. I hope everything is clear, and for any question, you can always ask me, call me anytime. Thank you.